Hello, Houston. Forgot to turn my fanny on, which is one of the problems of living in the modern electronic age. We're sitting here relaxed, coolly discussing the day, the weather, life, and we're ready now to continue into our further discussions of abnormal behavior. You will remember last time that we were talking, I didn't, but I was reminded of where we were, that we were talking last time about the definitional problems of abnormal behavior and the fact that ultimately when you say of somebody that's abnormal, you're making essentially a value judgment. And inherently that's going to be controversial. So we've got several different possible strategies for declaring behavior abnormal, but there's nothing that people or psychologists are universally going to endorse. And then as we got looking into the various types of abnormal behavior that are possible, I then suggested to you that you have what is called the medical student syndrome as a phenomenon that you need to be aware of. Benjamin Franklin, as I probably quoted to you last time, had a very nice saying about lawyers and representing oneself, and I will paraphrase that to suggest that if you have yourself for a psychologist, you have a fool for a client. So don't go trying to analyze the abnormalities of you, if there may be any. Go get professional help if you really start getting worried about the things that you read about in the textbook. So, that having been said, let's launch into a look at how we go about categorizing various forms of abnormal behavior. There's an interesting kind of historical note here that back around the beginning of the 20th century, I should say, back around 1900, Sigmund Freud had developed a categorization system that kind of listed out all of the different abnormalities, and he was campaigning internationally to have that system adopted as the organizational scheme for categorizing various forms of mental disorder. The difficulty was that there was another system represented by Emil Kraepelin that had actually gone so far as to popularize itself, and so the net result was that Kraepelin won out in the battle as to who and what was going to be represented by way of a description of abnormalities. And the net result is that in modern form, Kraepelin's work is now reflected in a document entitled The Diagnostic and Statistical Manual of Mental Disorders. As you might expect, we don't waste our lives in 5-second gaps saying that. We say instead simply DSM. And the only time you really need to be even more specific than that, you will hear somebody say either DSM-IV or DSM-IV-TR. That is the current version of the DSM. It is called DSM-IV-TR simply to differentiate the different editions of the book itself. And in essence, what's involved there is a representation of the various ways in which we can organize the system itself. That is, the DSM has actually had 6 different versions that have been represented down through the years. This is the current one, and it is a sizable tome, as you might expect, running to precisely 886 pages. So it's just a massive book with tremendous detail in it in terms of all of the different diagnostic disorders that we're going to talk about a little bit today. This is the 5th edition called DSM-IV because there was a 3 and then a 3R, and now there is a 4 and then a 4-TR, as in text revision. So although it's DSM-IV, it is actually considered to be the 6th edition of the book that has come out. What it represents is essentially a series of diagnostic categories that are utilized, and the categories themselves are actually subdivided in 2 different ways, and I'm going to show you one but not have you worry about trying to learn it, just so that it's kind of put in context for you. Excuse me. The DSM itself is divided into 5 what are called axes, and those axes represent different ways. You could think of them kind of as orthogonal representations of ways to capture the essence of whatever it is that's bothering you by way of mental illness, if anything is. Axis 1 has most of what we're going to be interested in, and that is what are called the clinical disorders, of which there are, 880 some odd pages, as we just suggested to you. The clinical disorders are the primary axis on which we're interested in whatever diagnostic label is applied. There is a second label, the axis, I should say, that labels essentially personality disorders and mental retardation. The point here is that, in essence, the first axis labels or identifies the primary clinical disorders, whether they be psychotic forms of psychoses or forms of anxiety-driven disorders and so forth, as we're going to talk about them. The second disorder, or the second axis, I should say, has to do with essentially illnesses or conditions that may be operating orthogonally, that is, on a different dimension relative to your own disorder. For instance, as an example, mental retardation, which is one of the things that is categorized on axis 2. Your mental state, high ability, moderate, low ability, does not necessarily directly impact the illness that you've got, but it may bear on it. So you might have an anxiety-based disorder on axis 1, and then be diagnosed as mentally retarded somewhere on axis 2, or falling somewhere on the scale of mental retardation on axis 2. So in that case, what I'm suggesting is that not everybody is going to have an axis 2 diagnosis. It will be there sometimes, but not all the time. But everybody, if you move through this with a mental disorder, a behavioral disorder of some sort, will in fact have a rating on axis 1. The other three axes are less important, but they also bear on the overall diagnosis, according to the American Psychiatric Association, and I'll come back and comment on that in a couple of minutes. Axis 3 involves general medical conditions. So normally when you're admitted to, whether it's a state mental hospital or for that matter even a community mental health system, oftentimes one of the first things that will be recommended before a diagnosis is fully applied to you is that you have a complete medical exam. Because clearly in some instances what we think of as mental disorders actually come from a chemical imbalance or some other medical problem that can be fixed medically without having to worry about any kind of psychological treatment. Axis 4 deals with psychosocial and environmental problems that you may be facing. We're going to talk a little bit later about the homeless in any city, including ours, and certainly homelessness would have an adverse effect on your behavior and might be one of the factors that would in fact impact the label that we would apply to whatever disorder you may have. So in some cases, in all instances, there will be a comment on the psychosocial and environmental aspects of the problem that you are experiencing, if you have one. And finally then, number 5 is a global assessment of functioning. That is very specific. It's a number between 1 and 100 that essentially is the clinician's estimate of your actual efficiency or efficacy in functioning. How well or how poorly are you doing in general? Obviously, what you're hoping for is a higher number, and the general suggestion would be that the higher the number is, the lower, the less the problem is, and the higher the likelihood of full recovery in general. So those are the 5 axes. The one that I'm going to spend the rest of our time on this issue talking about then is simply axis 1, which is the clinical disorders. I'm going to show you all of them, but then we're going to narrow in on a subset of the overall array. These 3 are pretty self-descriptive. The drug disorders, for instance, would be down in category 3, level 3 here, as we're talking about it, the third disorder that's labeled. These 2 in, what do we want to call that? Pink, magenta, pick a color. Pink?
It looks lavender.
Lavender, okay, let's go with lavender. I have a green weakness, and I get this feeling that it screws up all of my color perception. We'll go with lavender. I like that. The lavender conditions here are the ones that we're going to be looking at in a little more detail. One of them, and what I would argue is probably the single most severe form of mental disorder that you may face, is schizophrenia or some of the other psychotic disorders. We're going to come back and talk about those. We'll also look at mood disorders, which are a very interesting combination of not pure psychosis, as we'll see. The next group, isn't that a lovely group, actually has a very interesting lavender connection. There's a story behind why these categories are where they are. These 5 are basically, essentially, almost purely psychological in terms of the disorder that is actually reflected here. In the earlier versions, back to DSM-II, for instance, one of the main category 1, axis 1 diagnostic labels was neurotic disorder. And that was a general label that was applied, and you would be considered, for instance, to have neurotic disorder dissociative type or neurotic disorder somatoform type. So that these 5 categories were actually on axis 2 rather than axis 1. And then all of a sudden, there is a battle that's going on here, kind of behind the scenes. The American Psychiatric Association is constituted of MDs. MDs are very much about the business these days of making all mental disorders, i.e. all behavioral problems, have a medical basis. This has been fouled up in what you may have heard of as the blues suits. In essence, what's involved here is guild fighting, that is medical people versus psychological or psychologists. And what's at issue there is that the DSM is published by the American Psychiatric Association, which means that it's published by an organization of MDs. They are always about the business of trying to make every illness appear as a medically driven condition. The evidence is reasonably clear that the 5 that are listed on the screen here now don't have a medical basis. They're behavioral problems. And in fact, they were originally called neuroses. And that concept comes from, if you remember my treatment a couple of lectures back, from Freud. That is, psychoanalysis was the one that originally introduced the concept of neurosis into the literature. And so the psychoanalysts were incensed when 3R arrives, and all of a sudden, all the 5 category 2 neurotic definitions of disorders have been moved out to category 1. And I swear there was an article in the paper here in Houston when DSM-IV-TR came out, neurosis cured. And in essence, the only thing that had happened was that the label neurotic disorder had been removed from the DSM. And what they had done was to take the 5 category 2 or axis 2 labels and move them out to category 1. It had not eliminated neurosis, the condition hadn't been changed at all, the descriptions of the disorders hadn't been changed. The assertion was that saying that somebody had a neurosis was about like saying in medical terms that you have a common cold. It doesn't do anything by way of tracking down whether it's a stuffy nose, a scratchy throat, a problem in the stomach or the chest area, and so that was the rationale essentially. Now I'm oversimplifying, of course, but essentially what they were doing was removing neurosis and moving those 5 category 2 levels, axis 2 labels, back to axis 1. And that's the reason that those 5 lavender, thank you, terms are now included on axis 1. But any illness in those 5 categories would originally have been called a neurosis. It is now called simply a somatoform disorder, an anxiety-based disorder, and so forth. In fact, in general, those 5 are considered to be anxiety-based disorders. And I'll show you here shortly the role that anxiety plays in each of those 5 disorders in one form or another. That having been said then, let's go on and notice that there are some others that we're not going to talk about. Eating disorders, this would include, for instance, bulimia and anorexia nervosa as psychological problems, or the psychological component would fall under eating disorders. There are sleep disorders that will bother some people, impulse control disorders, acting out problems, and so forth, and then adjustment disorders. And then finally, we've got kind of a catch-all category, mental disorders from a general medical condition and then other conditions. So we'll capture you somewhere in the 17 or 18 labels that we've actually got here. But the ones we're going to go back and concentrate on are essentially the traditionally called psychotic disorders and the neurotic disorders and the mood disorders. And I'll show you why we've chosen those 3 here a little bit later. So in essence, what we've got here are 5 axes. The first one is the only one we're really going to concentrate on, and the 17 or 18, among the 17 or 18 categories, we're actually going to concentrate on about 6 or 7 of those and show you kind of a pretty good range of what psychological problems look like behaviorally. Now, as we get into this, there is an interesting problem that has developed down through the years. A classic study was done by Paul Meehl at the University of Minnesota back in the mid-1950s. And in essence, what he did was, in this particular study, was to challenge. It was published in 1959, and it was based on a problem relating to clinical as opposed to actuarial prediction or diagnosis. What Meehl did was to go into a state mental hospital in Minnesota and pull out 35 cases, people who in some cases have been in the hospitals for 30 some odd years already. So they had a pretty good idea of what the actual problem was, and that was kind of the answer key for a test that he created. What he did was to write up the cases as a series of symptoms, a presenting series of symptoms, and then he had those symptoms computer analyzed, that is matched to the best available diagnostic techniques at that time, given what then existed by way of diagnosis possibilities. And he also gave those same descriptions to a clinical/psychiatrist group. So we had clinical psychologists, psychiatrists, and a group of clinicians actually consult and diagnose each of the cases. And what he found was, out of 35 cases, 23 of them involved actuarial superiority, which is a dignified way of saying the computer won. The computer did a better job of diagnosing what the particular disorder was. In 12 of the instances, there was no difference in the clinical diagnosis of the computer group, computer analysis versus the clinical group, and in no instance was there clinical superiority. Now, that kind of a study, when it's published, is a real slap in the face, and as you might expect, generated a huge reaction. It also became the basis for the creation of the original DSM. That is, one of the several issues that was raised was simply the inaccuracy of any widely agreed upon diagnostic system that could actually be utilized. So in essence, the kind of studies that were generated here looked at, among other things, what problems do we face in diagnosis? And one of the obvious ones, if you think about the way we've defined it, would be reliability. There are two different types of reliability that we're particularly concerned with. One is what's called interjudge reliability. That is, will I agree with my colleague's diagnosis of whatever your disorder happens to be? And it's been demonstrated, for instance, in a variety of studies that to a certain extent, our diagnosis is meaning psychologist's diagnosis, is influenced by things like the race and socioeconomic status of the patients. Now, that does not include the fact that the only people that tend to go into psychoanalysis are the rich. That is driven entirely by the fact, first of all, that psychoanalysts are expensive, and secondly, psychoanalysis itself, as we'll see when we get into psychotherapy, is first of all very long-term and very time-consuming. That is, in a typical psychoanalytic treatment period, you're going to be in psychoanalysis 2 or 3 or 4 times a week, and that session is going to last, that experience is going to last over 2 or 3 years. Most of us are not rich enough to afford that length of time. So that, I think, is a false basis for suggesting that only the rich end up being diagnosed with problems that psychoanalysts would fix. There's a cause and effect relationship I would question there. But on the other hand, interpersonal skills, not only of the person doing the interviewing, but also of the person being interviewed, also impact the likely diagnosis that will come out, and that's a problem. We do know that the more extreme the disorder, the higher the level of agreement tends to be. So there are certain correlations that we can demonstrate judge to judge. There's a second type of reliability that we also need to worry about, however, and that is what we call test-retest reliability. Here, we get some rather interesting statistics. One study involved looking at something over 400 patients that were admitted to a state hospital over a 6-month period. And what they found was that the staff psychiatrists there, 85% of them could agree on the diagnosis of the major disorder. That is the Axis 1 label. 50% agreement was there on the specific subtype that was involved. And there was very little agreement on personality and neurotic disorders, that is the anxiety-based disorders, because they can take so many different forms. The follow-up, the obvious question then is, well, okay, given this variety, where are the errors actually coming from? And one study cited a rather interesting series of statistics. What it argued was that 5% of the errors are tracked to patient inconsistency. You interview somebody at one point, they act one way. You interview somebody at another time, they act in a different way. So patient inconsistency can be a problem. A second problem may be that the diagnostician acted differently on one time or weighted the symptoms uniquely one time as opposed to another. That was thought to account for almost a third of the errors, 32.5% if you're being precise about it. But a whopping 62.5%, that is 5/8 of the variability, was attributed to the inadequate categories of the diagnostic system itself. That was the kind of data that was utilized to create or justify the creation of the DSMs themselves. Now, the whole idea of creating a diagnostic and statistical manual leads to some very obvious criticisms from psychologists. One of them is the fact that to name something is not to explain it. Okay? That is a problem. To name it is not, to label it is not necessarily to explain it. The second problem we have is that the DSM focuses on the individual and stresses conformity. And what that means is that if you act unusually, by some categorizations, you might end up being considered abnormal in a mentally treatable form. Thirdly, the DSM tends to orient toward the past more so than the future, and that's a problem. The fourth is that to label the individual with a particular disorder may in fact remove from that person a sense of responsibility for trying to fix him or herself up. I remember there is a classic scene in the movie One Flew Over the Cuckoo's Nest. The ward scenes in that movie do a very good job of illustrating what a typical mental ward looks like under most situations. And there is a scene in there where the lead character in the movie, about whom the movie itself, One Flew Over the Cuckoo's Nest, was written, interacts with an Indian chief who is in there. And the character, and I'm paraphrasing here, but the main character essentially challenges the chief. Why are you in here? I mean, you're not mentally ill. And in essence, the chief's response is a kind of a classic of bureaucracy. And what he said is, essentially, the government has forced Indians to be on reservations. Mine happens to be in Arizona, in an area where it's either 10 degrees and snowing or 110 degrees and miserable. Here, I'm at 78 degrees, air-conditioned, I'm fed 3 good meals, I'm warm in the winter and cool in the summer, and it seems to be a pretty good life for me. And the bottom line is that by acting out, by being diagnosed as mentally ill, that person has essentially created a very adapted, well-formed life for himself. Yeah, we might question the lack of freedom, but he doesn't. And who's to fault him? Another real problem is that being labeled as neurotic or psychotic or having an anxiety-based disorder, whatever, does have a social stigma associated with it. I don't think I cited in my last lecture a study that I have always found hauntingly interesting. I don't have a slide to illustrate it for you, but the point is a fairly easy one to make. Are you familiar with a game called Labyrinth Spiel? You may not know it by that name, but let me describe it, and I'm sure you will have seen it. It's a platform that's about that square on a desk, and it's got 2 handles on it on each side. And what happens is when you twist the handle, the platform rotates slightly. So in essence, you can turn either of 2 handles and rock it left and right or back and forth. And it has a line pattern drawn on the surface. And what you do is put a marble or a steel ball or something on the start point, and there are a series of holes in the platform. So what you're supposed to do is kind of manipulate this thing and then roll the ball along the line from start to goal box. And of course, the danger is at any point if you roll over one of the holes, it falls through and you have to start over again. You familiar with that game? In this case, that game was used as the basis for a study involving undergraduates brought into the psychological laboratory, and they were introduced to one another, unknowing, each not knowing how the other has been introduced, but it was indicated beforehand, either you're going to be working with a fellow college student, or you're going to be working with a former mental patient who is being analyzed for possible admission to the university. And so this was introduced to each person among the 2 who were playing beforehand. They then did one rather interesting thing. Instead of having one person doing both, each person ran only half of the platform. So in other words, you had to do a lot of communicating with your partner, and there had to be some considerable cooperation if this thing was going to work at all. They ran the study for an hour. After 30 minutes of this, they stopped and asked a series of questions, one among which was, how effective, how helpful has your partner been so far? In the instance where people thought they were working with a fellow college student, the ratio was 9-to-1 in favor of, it's been good, it's been cooperative, it's been okay. In the instance where people thought they were working with a former mental patient, the ratings were still plurality positive, but it was 3-2. 60% said, yeah, helpful. 40% said, no, not particularly helpful. Even more interesting, at this point they were then also given a choice of, would you rather continue working with your fellow partner, or would you rather do the rest of the study alone? In other words, will you take one, or do you want to do both halves? In the instance where people thought they were working with a fellow college student, the vote was about 3-2 in favor of, I'd like to continue working with my partner. In the instance where the people in the study thought they were working with a former mental patient, the ratio was 9-to-1 against continuing to work with the former mental patient. I would argue that the biggest problem the mentally ill have in this country is not theirs, it's ours. I find that a very haunting study in terms of thinking of its implications, and I've not found any other explanation for it than the fact that we really need to kind of rethink our assessment of modern mental illness. I've already critiqued it. I should have pressed some buttons here. The statistics on mental illness, basically, as we move into therapy, are interesting. What they basically suggest is that well, let me just describe it in general for you. What's happened is that the number of people, and the graph that I'm referring to again is the one that was put on the last program. It's at the bottom of page 9 in the Simple Psych book. The dark bars in that graph basically suggest that the number of people in a mental hospital has been dropping steadily since the mid-1950s, and that in essence what has happened is that the number of people per capita has plummeted since about the mid-1950s. Did I suggest to you why that's actually happened? Did I offer up any potential for why that was actually happening? Talk to me here.
Better diagnostic technique?
No, it's not diagnostic technique. There's another actual explanation for it. Anybody got a guess? Nobody's bold enough to try it, huh? Yes?
Could it be because you said that a lot of the things that were once considered medical or whatever can actually be treated just by psychological means? Or just psychological?
Like all that neurosis stuff.
No. No, you're headed in good directions, but you're coming at it from a wrong perspective. There's a very simple explanation. Tranquilizers. Tranquilizers were first authorized in the mid-1950s. And the prediction at the time was that as many as 85% of the patients which formerly had to be treated would no longer have to be. And in fact, what actually happened is that the actual data, and I'm estimating here, but in essence, the actual data suggests that it's down around 90% of the people who at one time would have had to be formally hospitalized no longer have to be. And so the net result is that there has been a huge shift in the way in which we treat mental disorder now, and the number of people requiring treatment has plummeted substantially. And that, in essence, is what's represented by that bar graph in the Simple Psych book that we talked about at least briefly last time. I'm having trouble with my computer here for a minute, so if you'll tolerate me here for just a second. There we go. That's what I'm actually after. Now we can put that on the screen, and then life will continue full and rich and good here. But the point is that what that treatment problem has, or what that shift in treatment has created, is a very interesting subgroup, and it results from what is called the revolving door. It results in what's called the revolving door policy. The problem being that many of the people who are homeless in our city now, at one time would have been hospitalized mental patients. Certainly not all of them, but many of them. And what's happened is you're out on the street acting up. The result is that they arrest you and put you in a mental hospital, and they balance up your medical condition. They put you on a prescription. They get you all balanced up and release you, and you feel so good taking the drugs that you stop taking them, and pretty soon you're acting up again. And therefore you're arrested and hospitalized, and then you're balanced up and treated, and you're given a prescription. And that prescription, of course, is dependent upon, first of all, money, and secondly, enough personal responsibility to take it. So you take it until you run out of money, or figure, well, I feel good enough, I really don't need those drugs, and then pretty soon the symptoms are back. And so you've got literally a revolving door, and that's a problem. We don't have a social solution for that yet, but we've created a kind of a new subgroup of people based on the treatment strategies that are currently available, which have been a little bit problematic for us. Now let's look at the specific disorders here, and we're going to concentrate specifically on the anxiety disorders, the ones in light blue here first. The categories we've already talked about. Why am I burdening you with all this? I never quite know. Oh, I know what's going on here. If I'd stay up with my notes, everything else would work. In essence, when you look at those 5 conditions that we were talking about, the underlying driving force behind it is essentially anxiety. And the definition here on the screen is the underlying definition that kind of undergirds all of the 5 categories that I isolated earlier in the categorization. And in essence, if you'll notice here, there are 2 things that go on. The one is these are a group of personality disorders that are characterized by anxiety, and the fact that that anxiety interferes with normal everyday functioning. Those are kind of the 2 key features for anxiety-based disorders among the 5 that we're dealing with here. The key elements are, first of all, feelings of anxiety and inadequacy. That's one thing that will be a constant element across all of these types of disorders. The second thing, and it's interesting, is avoidance. Give you an example. Supposing you've got a phobia. You have a phobic anxiety about darkness. You're walking toward a building with a friend one day and realize, it's after dark, but you're with a friend, it's not a problem, that you're about to be asked to go into that building to turn on lights. And so you invent a reason to stop and bend down and tie your shoe and assure your friend, go ahead, I'll be in just a minute. And the result is that by the time you get in, he or she has already turned the lights on. And so in essence, what you now have is not a revolving door, but what clinicians call a vicious circle. Phobias are very difficult anxiety-driven disorders. They're very difficult anxiety-driven disorders to cure. And the problem is going all the way back to negative reinforcement as we defined it back in learning. Because if you think about it, what happens is the phobia crops up. You have this deep-seated anxiety of fear. The result is you engage in avoidant behavior, which doesn't expose you then to the darkness, and the result is you feel good. So the next time the anxiety crops up, you engage in avoidant behavior, which makes you feel good, and so the next time the anxiety crops, and so forth, and you're in a vicious circle. In that case, it's a problem which is clinically very difficult to actually treat. We'll come up with ways to do so, but you'll be amazed what we have to go to actually try and break into a phobia. And thirdly then, the last element that we'll also look at is self-centered, self-defeating behavior. And that essentially completes the cycle. So in essence, when we're talking about neurotic disorder, what are traditionally called neurotic disorders or anxiety-based disorders, we've got feelings of anxiety, we've got avoidance, and we've got self-centered, self-defeating behavior. Now, there are three different types of anxiety that we can actually talk about, and I want to identify the key elements here to be, first of all, anxiety as opposed to fear. What we're dealing with here when we have a fear is if you ask somebody who's afraid of something, they can usually tell you in great detail what they're actually afraid of. That is, you have a fear of, and something is named. Oftentimes with anxiety, it is generalized, and there is no one thing that you're afraid of. Do you remember what you feel like when you wake up the first morning of final exams? Can you imagine waking up every day of your life feeling that way? That gives you just an inkling of what it is to have a deep-seated anxiety driving you in a given situation. But we're dealing with anxiety as opposed to fear. Secondly, you're about to come into a period of time, as we described the other day, called final exams. And you may feel a little bit anxious, no surprise. That's okay, because when the time period passes, so does your anxiety. I mean, yeah, you're kind of stirred up right now, but you'll get through it. We all do. But again, think about waking up every day with those same anxieties. Now what you're dealing with is what's called a pathological anxiety. It's not normal. That is, it's not part of everyday life. It is rather one that is constantly there, and because of its constantness, interferes with our life much more thoroughly. The third is that what we're dealing with here is a trait of anxiety as opposed to a state. What I described for you at final exams time might be a condition of high anxiety, but it's a state. It's related to your immediate environment, and once the exam conditions pass, the anxiety state also passes. We do know that admissions into university-centered counseling centers peak at final exam time. There's a minor peak at midterms and a big peak at final exam times. And once you get through finals, well, the number of students drops, but the number of contacts with the agency also drops substantially. So that's an example of state-based anxiety. That's not what we're dealing with here. What we're talking about is trait anxiety, where it is a constant element of the personality. So in essence, in each case, it's the italicized term which is relevant here in terms of feeding into anxiety-based disorders. Now, the psychoanalytic view is fascinating. It is the theory which has most thoroughly treated this particular form of disorder. And in fact, the symptoms, as you will remember, trace out of the inability of the ego to control both the id and the superego. And the net result is that what happens is that the source, as I said, is a weakened ego that senses that it's losing control. The first thing the ego does is to create defense mechanisms. That is its standard response. If I'm having trouble controlling the demands of the id and the superego, I'll build some defense mechanisms. They are unconscious. And therefore, you and I are not aware of defense mechanisms when they are operating within us. Each of us can see defense mechanisms in other people, but we cannot see them in ourselves because they're unconscious. We are not aware that they're working, that they're occurring. A really interesting paper was done a number of years ago to categorize the types of defense mechanisms, and this has withstood the test of time pretty well. It suggests that the common element to all defense mechanisms is basically repression. That is, that there is some degree of repressed energy. There are unconscious urges within you that are being actively suppressed by the unconscious. And so the general idea of repression is a constant element of the defense mechanisms as they occur. The second broad class are those that involve escape or flight of some form. You may remember here in Houston a couple of years ago, right around the turn of the millennium, there was a story in the newspaper about a NASA-based engineer who went to work one morning and disappeared. He was simply he was just not available for about 2 or 3 weeks, and the family was understandably quite worried. And at that time, it ultimately happened that he was found down in Florida somewhere with no memory at all of the fact that he had a well-paying job here in Houston at NASA. And in essence, in that case, what you had was an example of amnesia. In essence, what we call psychogenic amnesia with fugue. And I'll come back and talk about that a little bit later. But amnesia is one form of a defense mechanism that will operate. If you're having troubles, just forget about it. Easiest way to handle it. Denial is another one. The Walter Mitty in each of us that likes to strive to play on the New York Giants professional NFL team, even though we don't have the ability to do so, well, we'll buy our way in. That's essentially denial of actual ability levels. Phobias would fit under this same general arena here. And in essence, the existence of phobias, like claustrophobia, is ultimately treatable. It's easily treatable. A number of years ago, I ran a workshop for high school psychology teachers, and at this point in the lecture, I was talking about a fear of spiders, or a phobia about spiders as one example. And I actually had a teacher get up and leave the room at that point. And some colleagues were teasing her at the coffee break afterwards, and it turned out she had a very serious phobic reaction to spiders. And she even left the area where the people drinking coffee were teasing her about it, and I kind of chastised them afterwards about that, because it turned out when you talked to her, she had an extreme phobic reaction to the extent that she couldn't even sit in a classroom and discuss the condition, let alone actually, it was just, she organized her life around not seeing spiders and never being where they actually are. It's treatable in ways that we'll get back to here a little bit later. The third general group are those that involve disguising the relationship in one way or another. There are several different ones that are involved here. One of them involves, well, let me back up a little bit since I don't have an actual visual description there. Displacement. The husband of the family, who's the only one working outside the family, gets yelled at by the boss at work. He comes home and yells at the wife yells at the kid, and the kid kicks the dog. So the result is the dog got kicked because the husband got yelled at work. In each instance, what's happened there is, instead of dealing with the higher authority source and solving the problem there, each person has displaced the aggression that they're feeling onto a weaker member in the overall social hierarchy. Okay? So in essence, what we've got is displacement of aggression, or displacement as a defense mechanism. Projection is another one. Projection essentially would be attributing undesirable features of yourself to someone else. Okay? Projection as a defense mechanism. Or rationalization. You ever get arrested for not arrested, but you ever get a speeding ticket? There's always a perfectly logical explanation for why you're speeding, yes? But the fact is, if you're doing 85 in a school zone, you're still speeding. But it's a defense mechanism. We are never wrong, right? That's defense mechanisms that are operating. And then finally, those that involve modification of the impulse. And there are several of those that can also be cited. Compensation is where you make up for deficits in your own behavior by overachieving in that or a related area. The mother of Gypsy Rose Lee was widely thought to be what's called a stage door mom. That is, she was very marginal as a burlesque dancer, and as her daughter Gypsy showed more and more skills in burlesque dancing, her mother became more and more a presence in her life. And what she was doing there was kind of living off the reflected glory. So she was compensating for her own weaknesses, inabilities as a human, by living off the reflected glory from Gypsy. Reaction formation is where you develop a behavior that is exactly the opposite of what you feel. So that if you hate the boss, what you do is go out of your way to make it seem as if that is the most significant, dearly loved person in your entire life. And my favorite is sublimation, where what Freud argues happens here is that we express unacceptable impulses in a socially acceptable manner. So if you have a desire to cut and hurt and maim and destroy, you become a surgeon. I'll let you think about that the next time you're being operated on. But the defense mechanisms of Freud's are essentially an interesting kind of treatment of the way we deal with anxieties. And that is what he's arguing theoretically is that we manage. We erect explanations for what's going on in such a way that we're comfortable continuing to live with ourselves. Now, There are a number of different disorders that we can talk about. And so what I've done here is just kind of pick out a series of them. And I'm going to just use a kind of a series of these to illustrate the general phenomenon. And I'm doing a little shuffling of notes here because I've rearranged the traditional way in which this is presented here. When we talk about panic disorder, which is one of the types of anxiety-based subtypes, if you want to think about it that way, a panic disorder is defined specifically as a disturbance characterized by the occurrence of one or more, quotes, unexpected panic attacks that are not triggered by the person's being the focus of others' attention. You have to experience at least 4 in a 4-week period in order to qualify for having a panic disorder. And the attack itself will involve shortness of breath, palpitation of the heart, dizziness, fear of dying, a fear of going crazy. All of those are elements that may show up in a true panic attack. It's not usually set off by an immediately identifiable environmental stimulus, although it's often related to the loss of a significant relationship. The attacks usually subside within 2 or 3 minutes, but simply walking up and slapping your arm around somebody who's having a panic attack is going to be no use at all. It is internally driven, it's reacting to internal stimuli and that person's perception of his or her world, and outside assurance is not going to help in that situation. A related one is agoraphobia. That's being in places or in situations from which escape would be physically or psychologically difficult. As free running as this particular classroom is, people are, although you may not see it on camera, you'll occasionally see a head bob by when somebody hasn't ducked low enough. People would feel very trapped in this kind of a classroom if they were agoraphobic, or they could make themselves feel trapped, because in essence what they would think to themselves is something like, he, that is me as the instructor, is going to target me if I get up to go to the bathroom or outside to cough or anything like that. That I'm going to be targeted and I'm going to be the object of personal attack and I will be humiliated and so forth. And so in essence, even in a perfectly free environment, people who have agoraphobia can convince themselves that they're psychologically trapped. So where claustrophobia is related to enclosedness in a seemingly tight area, agoraphobia is an even worse condition because you can talk yourself into being an agoraphobic without having any necessary strictures at all on your limits on your behavior. So in fact, if I can keep my fingers up with my mouth, everything would work a lot smoother here, I guess. But that's the technical definition of agoraphobic. It's in the book, so I'm not going to spend a whole lot of time on it. There are some other activities that also are related in addition to panic disorder. Another one is obsessive compulsive disorder. Have you ever woken up in the morning and had a tune going through your head? You get to breakfast and you find yourself still humming that tune. You're driving to school, you're humming the tune, and now you're beginning to worry about it. By noontime at lunch, you're still humming the tune. You ever had that? That's an obsession. Okay? An obsession is basically a persistent preoccupation with a particular thought or pattern of thoughts. Okay? An idea or a feeling of some sort. It becomes a compulsion if you start acting on it. Okay? Many years ago, interestingly enough, it was the same day that I had the experience on the subway in Cambridge, where I described the example of the double approach avoidance. Earlier that day, I had been walking along the streets in Cambridge, and I heard the sound that an automatic camera makes, you know, the click whir when a film is taken and then automatically advanced, a picture is taken, and the film advances. And I heard this click whir, and I was deeply thinking about something or other. And it suddenly kind of registered, gee, that's the 5th or 6th time I've heard that. And I kind of registered where I was and kind of focused on what was going on. About 30 feet ahead of me on the sidewalk was a guy walking along with an automated camera in front of him, and he had it focused on the feet of a woman who was another 20 or 30 feet ahead of him. And he was taking pictures about every 5 or 10 seconds. And it's amazing how we rationalize these things. I thought, oh, how interesting, an ad campaign. And I just watched what was going on, and we walked, I don't know, 2 or 3 blocks, and he was taking all these pictures. And then all of a sudden the woman turned into a store, and the guy immediately stopped, looked very annoyed, put his camera away, and turned off and went in a different direction. So it's clear to me, in retrospect, that what I was actually looking at there was a compulsion. That is, that somebody had an obsessive compulsive disorder. I don't know whether it was black leather shoes or women's ankles or stockings. Who knows what it was. But there was something about the lower part of that woman's anatomy that really caught his attention, and he recorded it with probably 25 or 30 pictures in a 5-minute period. That's a compulsion, okay? That's a person who needed help. Now, let's look at another one called somatoform disorders. Here, what you've got is a case of literally mind over matter. This is what actually happens here. It's an anxiety-based pattern in which individual complains of bodily symptoms that suggest the presence of a physical problem for which no organic basis can actually be found. In other words, the symptoms are there, the complaints are there, but there's no physiological evidence that it's actually happened. This is a person who's very preoccupied with the state of their health. And it can show up in a variety of different rather interesting conditions, which don't include dissociative disorders. So let me finish with my examples here first. One of them is long-term somatization disorders, where somebody complains for years about, I mean, there are instances of people who've come into a mental hospital with what's called somatization disorder that will have as many as 35 different physical symptoms that they're complaining of. And the usual reaction is, when the doctor can't find them, well, I'm going to go get another opinion. In essence, is the response there. It's just complete denial that, in fact, maybe the doctor is right. There are no symptoms. Hypochondriasis is another one. And one of the original ones that comes out of this area is what's called a conversion disorder, which is, in earlier times, this was called a hysteria. One of the interesting examples of this is a musician, a professional musician, who's actually appeared here in Houston, a pianist, an internationally known musician by the name of Leon Fleischer, who is a very well-known, internationally known concert pianist. His career was put on a dead hold for almost 30 years when he woke up one day, as it is told, and experienced what is called glove anesthesia. That is, in this, when this happened to him, this part of his hand he had no, or this part of his body he had no control over. That is, he lost all feeling in one of his hands, his right hand. Now that can't happen physiologically, because the sensory nerves feeding this hand are this way, okay? So you might lose control here, but if you do so, if you lose the left and the fourth and fifth fingers, you're also going to lose feeling on the right side of the hand and down into this part of the arm. If it's on this side, then it may come into this part of the palm and down the arm on this side. But there's no way, unless you have a truly bizarre, which didn't turn out to be the case with Fleischer, disorder where you've got two different nerves impacted in two different areas simultaneously. It was purely psychological. The result was that for about 30 years, he could only play left-handed pieces. And he now is back, much to his credit, on the performance stage again, doing a fairly constricted series of two-handed pieces. But in essence, it was a conversion disorder that he experienced in that case. Now, the other one that I want to look at is dissociative disorders, and we'll try to finish with these. In fact, I'm going to talk about a specific one here, and that is the dissociative disorders. Psychogenic amnesia and fugue I've really already described. The amnesia is the loss of cognitive contact with some prior event or events. The fugue is the fleeing, the actual fleeing. So the engineer I described earlier would have been described as having a psychogenic amnesia in fugue state. Okay, that is, he not only could not remember, he'd actually fled the immediate environment. The other one that is interesting here and has attracted a lot of attention over the years is what's called dissociative identity disorder. The classic example of that is the work of a movie that you may remember that won an Academy Award in the late 1940s called Three Faces of Eve. The Eve that was actually involved there is a lady named Chris Sizemore, who wrote a book in 1975 called I'm Eve. And in that book, she actually described the nature of what she'd gone through over the preceding 25 years or so. She was the guest of my students here at the university about 7 or 8 years ago and held them spellbound for 75 minutes just talking about her view of what had actually happened in the condition. It is the case, for instance, that the DID, as it's now called, it used to be called multiple personality disorder, it's now dissociative identity disorder, tends to attack people who are extremely bright. Because you and I carry around a lot of information about who we are, and if you actually have to switch from one personality to another, as happens with those people, you have to have a lot of attention to, now let's see, I'm this personality right now. Do I take cream with my coffee? Do I even drink coffee? Do I take sugar or do I take sweet and low? And so forth. And you think about that just related to a cup of coffee, you got to deal with all that and do it cleanly if the defense is going to work. The net result is that there is often, well, one of the examples that she cited was a woman who actually was menstruating on 3 completely different cycles depending on which of 3 states she was actually in. She had a friend in Chicago who was diabetic in one of his personality states. So it's a classic example of mind over matter. And the ultimate solution in her case was a very carefully worked out diet rebalancing and a coming to grips with the anxieties, because she had seen a friend of her father's get an arm cut off in his mill in a farming accident, and her mother burned herself in very close order, and that's what precipitated the backing away from the identity, the disassociation that led to that multiple personality disorder.